Okay, good morning and welcome to Surgical Pathology, digital slide review and sign out with Dr. Hassel this morning. So we're going to stick with the pancreas for a day or two. And here, as you can see, is a section of pancreas. We've got the splenic artery here, a nice thick-walled blood vessel. We've got a lobulated, multilobulated parenchyma. And in addition to these nice ink marks here denoting some abnormalities, we see there's some variability in the nature of the parenchyma. A lymph node over here, peripancreatic fat here, and so forth. But we see here's an area of some abnormality. We see there's some abnormality here, and then of course what the dots are highlighting over here. So let's start first with this area up here and hone in on that and see what we find here. This looks like a fairly normal pancreatic lobule here adjacent to it, but here we have some large ductal structures, epithelium with peripheral nuclei, fairly uniformly oriented, but they're in a location where they don't belong. So even though these glands cytologically have very little atypia, there's some, you see a few nucleoli here, but still have ample cytoplasm and basally oriented nuclei. This is glandular tissue that is in a place where it does not belong. And in the pancreas, that's a very helpful criteria to discern the presence of malignancy. So we would look at these glands in this location out on the periphery, almost into the adventitia and peripancreatic tissue, as being infiltrative glands. Normal ducts of this size would be located within the lobule or within the parenchyma of the pancreas, not out on the periphery. So that's a very nice first sign of malignancy here. Let's look next at some of the ducts here within the pancreas that may still be normal or may be neoplastic. In fact, this duct here is fairly centrally located, but as you can see, again, the size of the cells and the nuclear configuration is somewhat stratified and elongated. So this is not a totally normal, benign duct, even if it's in an anatomically appropriate location. This would be at least intraepithelial neoplasia. And then we see there's a few glands around it here that show some fairly significant atypia, higher NC ratios, irregular infiltrative pattern, and intraluminal inflammation suggestive of tumor diathesis. So again, this would be an area of intraepithelial neoplasia with some invasive tumor as well, provoking an inflammatory and desmoplastic response. Coming down here to this area of abnormality, again we see a fairly large duct and some destructive nature of the tissue here. So this also may be neoplasia. It's a little bit harder to identify as such because it seems to have a relation to this sclerotic lobule here. But here notice that we have sort of an incomplete gland. We have epithelium comes along here and then it stops. And instead we have coming into the lumen inflammatory cells, some histiocytes and so forth. So this would be an example of an incomplete gland with a tumor-like diathesis within the lumen. And then finally, kind of the coup de grace, certainly the easiest finding here to identify in this lesion. At low power, you see lots and lots of perineural invasive neoplasia. So here we see actually the nerve itself being split apart and surrounded by these same type of glands that we saw elsewhere in this case, with mostly basal nuclei, but again, some luminal inflammatory cells. So this is an example of a well-differentiated ductal type adenocarcinoma with several of the key hallmarks that we look for in defining malignancy. Areas of in situ neoplasia, small glandular infiltration, large glands located in places where they don't belong, and finally, perineural invasion. All of those are good hallmarks for invasive neoplasia. Now, we haven't looked at the lymph node, which we should also look at here, because lymphatic invasion, either direct extension or involvement of the lymph node, would also be an important prognostic as well as defining diagnostic feature. But in this case, it looks as though the lymph node here has not been invaded and is still pristine or naive relative to the tumor.